So good evening to everybody. Thank you so much for your interest in our webinar series. We are continuously ensuring that our work and our teaching is in line with the CAS values, and we have been working together in our different roles within CAS. So thank you for everybody returning for the second webinar in the series, and hello to any of the new attendees. In webinar one, we introduced a case. We spoke about the identification and the diagnosis of ADHD, and we spoke about the role of the GP in shared care and stimulant prescribing. So this evening in our second webinar, emphasizing as we did in the first one, that we have quite a short session, and this does not replace comprehensive training packages that are available for GPs on neurodevelopment, and particularly not the training program that's been introduced by the RACGP around assessment and diagnosis. Again, at the beginning of this session, I really do want to recognise that GPs have a wide skill set and manage many more conditions than specialists do, and you do that both safely and well. And so our aims for this section are to outline the common co-occurring conditions for ADHD and to introduce some concepts around non-medication management, strategies, and the role of the GP in assisting families in accessing these. So reintroducing everybody to our case, Danny, we met him last month, and on that first session, we reviewed his journey with the Child Development Service and his transition to shared care and medication prescribing with his GP. So for those who didn't attend last month, this is Danny's brief story. So he underwent his first assessment with CDS Pediatrics when he was 4, and those early concerns that were explored were around early language delay and some differences in social skills. He underwent further assessment when he was close to 7, and this time there were more prominent features of difficulty with attention, memory, organization, hyperactivity, and managing his big feelings, and we explored a bit further the family history of ADHD. ADHD combined subtype was diagnosed at age 6 years and 10 months. And after a period of time establishing Danny on medication, we determined him to be eligible for shared care with their family's GP when he had just turned 8. So now we meet Danny again when he's 9, and he's now got some additional difficulties that the family want to talk to you about when they come in for one of their scheduled reviews. It turns out that things aren't going so well, and so they speak to you about some difficulties with school refusal. Danny's now crying when he's separated from mum, and at home he started sleeping back in her bed every night. The family have gone ahead and spoken to school to see if anything's happening there, and the teachers have revealed that he's really struggling in his reading and writing and is probably between 1 and 2 years behind his peers. His confidence is dropping, and he's beginning to refuse to do the work that's set for him. And again, thinking about way back when he was 4, it seems now that those prominent issues with social skills are coming up again. He's struggling with friends. He's becoming really easily frustrated, and he's getting can be aggressive, both verbally and with some shoving and low-grade physical aggression. He's getting upset when things change unexpectedly, and so his teacher isn't entirely sure that this is all due to his ADHD and has made the often common comment of there must be something else going on. We have a very brief amount of time to skip through neurodevelopmental conditions. So what I really want to do is to highlight some things and just to have them in front of mind when you see these kids in your rooms with ADHD. So years and years of research has shown that ADHD is polygenic. So there's no one single genetic difference. And we know that there's interactions between environmental and genetic factors that result in kids and adults presenting with ADHD. So the presence of co-occurring conditions really is the rule rather than the exception. We know that all of these conditions are not clinically discrete and independent of each other, and ADHD symptoms are often embedded within a range of other developmental and behavioral concerns, including problems with learning, with emotional regulation, and with social functioning. But despite this rather pretty colourful diagram, it has to be highlighted that things are not always positive when it comes to co-occurring conditions. And actually, these comorbid disorders can really contribute substantially to kids' functional impairment. And so this is with their emotional, social, and educational function. And the co-occurring conditions are often associated with long-term problems for our kids with ADHD. I've tried to link these estimates to Australian studies and review articles, but as you can see, there's definite variability. Firstly, any co-occurring condition in neurodevelopment or mental health, for young people with ADHD, there's a co-occurrence of at least 60%. For language disorder, we know that language problems are really common in kids with ADHD, and they're associated with really markedly poorer academic function that's independent of their ADHD severity and other comorbidities. With autism spectrum disorder, we're going to touch on that in the next few slides, but there's a very strong co-occurrence with autism spectrum disorder. For anxiety, some estimates are even higher than 50%, and again, we're going to spend some time going into that. There's a wide variability in estimates for learning disorders, but the most prevalent learning disorder is a specific learning impairment in writing, and this is actually twice as common as a learning impairment in reading or maths. But either way, we have to really think carefully about academic performance in kids with ADHD and not thinking that it's entirely due to their attention problems. The final condition, developmental coordination disorder, was previously termed dyspraxia, but it's a disorder where motor coordination is really affected. And there's quite a strong co-occurrence with ADHD, and some estimates are much higher than 20%. But we know for kids with comorbid DCD and ADHD, they have significant mental health challenges. And that's important to think about for these kids in terms of participating with regular childhood activities. Autism. I feel like I can't stress this enough. This is an incredibly nuanced area of neurodevelopment, and that specialists are constantly learning new things. So this is really a brief overview and just highlighting some things to think about. There's multiple infographics that are available if you did a Google search, which outline the differing and the shared features of ADHD and autism. So the overlapping features for both include a difficulty in maintaining focus, interrupting other people, emotional dysregulation, sensory issues, and difficulties with executive function. We know that when autism is the primary diagnosis, up to 80% of those kids have symptoms of ADHD. And looking at from the other aspect for kids with ADHD, and this is backed up by research that I did on our own caseload, 1/3 of those kids also have a diagnosis of autism. So these slides outline what the additional areas beyond what is typically seen with kids with ADHD, which might mean that more investigation is needed. So the first area that we think about is social communication and interaction, and there are 3 different aspects of that. So firstly, communicating with other kids and other adults in a social way. So these are social greetings, these are participating in conversations with the to and fro flow of conversations and understanding other people's emotions. Secondly, we think about non-verbal communication. So these are things like facial expressions, body language, gestures, and eye contact. And thirdly, we think about the way that we interact with other people and build relationships. So the willingness and the comfort and the skills that they have with being with other kids and developing and understanding friendships. What we call the B criteria are the features of difference in thinking, behaving, and sensing. And these are things that are often much more prominent and that parents will often come to you about. So doing things in a repetitive way. So this might be moving their bodies in a repetitive way, sound making, saying words, but also some repetitive forms of play. We also think about the difficulties that young kids with features of autism have with change. They really struggle and become quite anxious if things are not kept the same, if things change unexpectedly, or if things are not done in a particular routine, often insisting that family members or other people follow the child's rituals. Thirdly, super interests, and I call them super interests rather than obsessions, but this is where an interest becomes kind of overwhelming other interests. It becomes very perseverative and quite narrow, and kids often really want to talk to you about them. They want to read a lot about them, and it kind of stops them participating in other interests. And interestingly, they also can get quite idiosyncratic interests. So I always tell the story of my little boy who absolutely adored whippersnippers and would talk to me for ages about those. So delightful, but can be impairing. And finally, for what we call B4, these are differences in sensory perception. And we all have many senses. So how things are seen, how things are felt, how things are heard, how things taste. And these might be either an oversensitivity or an undersensitivity to these sensory inputs. Assessment and diagnosis of autism. Again, that's not a topic that we haven't got adequate time to go into, but I really want you guys to refer back to the clinician assist page on autism diagnosis because it's really quite informative and it tells you a lot about assessment services. So for the GP, the essential roles in primary care is really supporting families, supporting individuals, and knowing that there are pathways available for families if they do want to pursue a diagnostic assessment. And so assessment can be undertaken by public and private services, and these obviously vary depending on geographical location. But public services within Perth Metro are the Child Development Service and the Department of Communities. There is a national guideline for the assessment and diagnosis of autism in Australia. And this I have got from their document, and I've popped that into the resources that are going to be shared at the end of the webinar. But essentially, assessment and diagnosis needs to be undertaken by clinicians that are experienced and well trained in this particular area of neurodevelopment. There are some pathways for a single practitioner, such as a medical practitioner in community child health or pediatrics, or a psychologist with endorsement in clinical psychology, can undertake what we call a single clinician assessment. However, the majority of kids within public services most definitely undergo a team diagnostic evaluation, and that's where multiple members of the team really look at all the different aspects and make sure that we consider all the possible differential diagnoses. And all assessments have to be undertaken with reference to the DSM, and they should be really of high quality, of depth, and with information from multiple sources. Anxiety, again, is a very large area, but I just wanted to talk a little bit about some of the common presentations that we see with kids with anxiety. So in a study done by a team in Melbourne, up to 50% of children with attention deficit hyperactivity disorder, read that from my notes, also meet criteria for a comorbid anxiety disorder. And so we know that there are multiple pathways that might account for this. And thinking about each of those in turn. So firstly, kids developing anxiety secondary to their ADHD, they are chronically failing, they're chronically being told off, they chronically feel that they're just not good enough, and that anxiety and low mood might evolve. Secondly, the ADHD symptoms might be secondary to a primary anxiety disorder, and that attention problems are arising because kids are either hyper alert or ruminating on different aspects of things in their life. The third is that ADHD and anxiety are completely separate and they may be arising from different pathways. And fourthly, as with all neurodevelopmental conditions, we might just not have a name for comorbid and anxiety and ADHD presenting together. So these are three of the common types of anxiety that we see. Firstly, separation anxiety, and then social anxiety and generalized anxiety. And we know that each of these can really result in much poorer quality of life and daily functioning, not just for the child, but also for the family as well. They're really quite difficult to manage. But we do also know that there's a tenfold risk of poor academic performance for kids with ADHD and anxiety. So it's something that we really have to keep our antennae up for. So despite the really high prevalence of anxiety in kids with ADHD, the research is still kind of looking to see what the best interventions would be for them. And Claire, later on in this discussion, will talk about some of the ways that we can access help from primary care, but the key management strategies are listed here and again can be found in the clinician assist guideline. So for individuals in primary care, it's really thinking about monitoring, making sure that we've got developmentally appropriate expectations because there's a lot of anxieties that are entirely appropriate at different ages. Providing psychosocial support for families, looking at accessing psychological therapies, and when it's getting to the stage where daily function is being really significantly affected, reaching out for those next level services. So language and learning disorders also have a really high co-occurrence with ADHD. And as I mentioned before, it's not well, it is important not to assume that poor academic progress in class is entirely due to poorly managed or untreated ADHD, particularly if there's a family history of learning issues. And parents may or may not have undergone assessments, but certainly if they report a childhood diagnosis of dyslexia, or even just asking about their school experience and finding out that they found school really hard and they didn't complete high school. So on the slide, these are the criteria that are listed in the DSM. But put really simply, a specific learning issue is one that can't be accounted for by low cognitive ability. So if your IQ is measured to be within the typical range, but you've got performance in a particular area of learning that is discrepant to that. This slide just outlines the different classification of learning disorders. So there's impairment in reading, impairment in written expression, and impairment in mathematics. And as with all things in medicine, it gets defined in different ways in different eras. So previous eras would use the term dyslexia, and that's still used in some in some groups, and dyscalculia. I guess what's important to know is that this is something that can be really helpful for targeting education. However, the Child Development Service doesn't offer school age cognitive assessments, and unfortunately, we have to decline referrals when that's the key request. And we don't do assessments of academic performance. So kids in public education schools are serviced by the School Psychology Service, but we are really aware that they're stretched across multiple schools. We're also really aware that at present, the Education Department doesn't provide individual student funding for kids, even if they do obtain a diagnosis of a specific learning disorder. But there is funding available for schools for specialist programs if they've got groups of kids with the same presentation. And a formal diagnosis can confer some accommodation in timed assessments, such as the NAPLAN and the ULNA. So again, in primary care, the main aspects of care would be, again, making sure that we've considered differential diagnoses, that we monitor, that we work closely with schools, and that there may be some families that may be able to access private assessment services. So taking a breath and a quick sip of tea, excuse me. Non-medication management for ADHD. So here in Australia, as far as I'm aware, we still have the most up-to-date evidence-based clinical guideline for ADHD in the world. So it was released in 2022. And so best practice is outlined in this guideline. And it's also backed by really large studies that have looked at different forms of interventions for kids with ADHD. On the slide, what we can see are the key pillars of ADHD management. So firstly, psychoeducation, making sure that people understand what it is and how it can affect young people, that we link families with supports, and we also make sure that we support the big people in kids' lives. We develop goals for management and making sure that families are involved in that. And then multimodal treatment is something that you'll hear a lot of, and that's a combination of lifestyle changes, non-pharmacological interventions, and pharmacological interventions. And again, before we get any questions about that, that's going to be the theme of our third webinar. Will be all about medication. So the principles behind non-pharmacological treatment are that ADHD is a lifelong neurodevelopmental difference, and often that multiple family members might have similar features of difference. And so interventions outside of medication are really about developing life skills for managing your mind throughout the different life stages. Research has consistently demonstrated that non-pharmacological interventions have got real clear benefits for families in their function and in their psychosocial well-being, but not for the core symptoms of ADHD. So when the guideline looked at each of these interventions in terms of categorically measuring the strength of evidence, the evidence supporting these were actually low to very low, but the recommendations for their implementation were really strong. Because again, in a research paper, you have to look at what their outcome measure was. Parent training and support really remains the key first line intervention for preschool age children. So these are kids aged less than 6. And our role as caregivers and as medical providers is really to provide support for families and to coordinate ongoing referrals. So in a review appointment, what we're looking for is to review the home and school situation, have a think and a chat about any new challenging behaviours or situations. We look at lifestyle, we look at diet, we look at sleep and exercise. We think about mental well-being and then specific mental health issues. And then we also think about any symptoms of emerging comorbid conditions, like the ones that we've just been speaking about, particularly around mental health, so anxiety or depression. Kids sleep. Kids sleep is something that all the parents in this group and all the parents that you will see will often have difficulties with. But for kids with neurodevelopmental issues, it's really very common. So up to 70% of kids with ADHD will have some form of sleep problem as related by their parents. And the most common is getting to sleep. So sleep initiation. And this is independent of medications, which can also affect sleep initiation, but kids just have real trouble winding down. But other sleep disorders can include behaviorally based insomnia, so just refusing to go to bed and parents having trouble with limit setting, circadian rhythm sleep disorder, where they just don't feel tired at the typical times. And that's been backed up by research looking at melatonin spikes happening at the wrong time, and also conditions like restless leg syndrome. We know that sleep hygiene measures improve between 20 and 40% of those sleep issues with ADHD kids. So we really recommend that we try those first. So ones that are commonly recommended for healthy sleep practices is routine and kind of training the body to get into different routines. So going to bed at the same time, getting up at the same time, going to bed in the same place, and having a kind of calm, settling evening. So no exercise, running around, getting excited, watching exciting things, playing on electronics. Caffeine, less so for kids, but there might be teenagers that are drinking lots of Red Bull. But really having a think about getting the body and the mind ready for sleep in the way that it has evolved to do. Screen time is also enormous and probably beyond the reach of this brief webinar, but children use different types of screens every day. So this can be phones, tablets, gaming devices, computers, laptops at school, TVs. And so the research into the effect of screen time on kids' development is difficult because everything is changing so quickly. We do know that using screens a lot does affect sleep, and it does affect accessing other activities like physical activity. And these are both really important for health and development. We know that getting enough sleep and physical activity are research linked to reducing ADHD symptoms. So we have to really support our parents that we have in our clinic rooms about how we can help to manage this. So thinking about things like parental controls, thinking about things like family contracts, and for families to be ready for the emotions that kids can feel in those transition times coming off screens. So being ready to support them to move through those big emotions when screen time ends and not feeling as though it's just your child, because it's often most children, but the kids have to be involved as well. So parents need to talk to kids about why screen time needs to be balanced with other activities and having a think about household rules that the kids and the adults stick to. So in summary, and I've been talking a long time, in a shared care arrangement for kids with ADHD, there's much more to ask about than just medication and measuring their growth. So understanding the issues that run alongside ADHD can really help you to support them and to make a significant positive change for our kids and our families. So now I'm going to hand over to Claire, and she's going to talk a little bit more about the role of GPs in these management plans.
Thanks, Fiona. I will just myself sorted. Okay, so this bit is a little bit dry, so I do apologise, and I'm not trying to teach you all to suck eggs because the MBS is wild, and there's lots of different things within this that as GPs you'll be doing on a daily or weekly basis. But also just to say that I'm not an expert in the all of the management plan item numbers. So I would recommend that you satisfy yourself with the MBS website that you're doing all the requirements for each item number. In general, I'm just looking at, or what we're looking at today is the GP item numbers that can help unlock or access some of the help and non-medication management strategies and referrals that can help for children with ADHD. So the first ones, everyone I'm sure will be very well aware of the relatively recent changes to the GP chronic condition management plan and the new very long acronym that they've put in there as well. But the eligibility requirements have changed to be quite simple in that the patient eligibility is really that they just have one chronic condition lasting equal to or more than 6 months, and ADHD in and of itself will qualify for that. There is no longer a requirement to have 3 health providers involved, which was a question from the last webinar. But the GP that claims it does need to be a GP at the My Medicare registered practice if the patient is registered with My Medicare, and non-registered patients can do it with their usual GP. And this has probably provided some issues because it's not very simple to swap and change very quickly for this if a patient has been previously registered to a different practice. And in addition, the particular management plan item number, so the 965, for instance, would have to have been claimed before the allied health can be claimed, and there's a bit of difficulties there if your patient is unknown to be registered with another practice and it gets rejected. The telehealth item numbers do come with a couple of additional requirements, including having an established practice relationship and also being seen in person in the last 12 months, with some exclusions to that, including children under 12 months and COVID-19 isolation still, etc. So essentially, in the kind of new so-called simplified version, you could do the GP-CCMP item number initially, and although a practice nurse, if they've never had one before, can help with the making of the plan and the formulation of the plan in the initial item number, if they haven't had one before, they can't claim the nurse item number. But on subsequent reviews, if the nurse contributes, then they can claim that item number. And this unlocks, so to speak, the allied health services, which in general population is 5 individual sessions per year. They unlock the rebate. They don't really probably ever fully cover the cost of the allied health sessions. So it's really important probably to advise your patients that there will almost certainly be an out-of-pocket charge. And unfortunately, for a lot of patients, that is, especially in this cost of living crisis, quite a difficult and challenging thing to meet as required. For Aboriginal and Torres Strait Islander patients, they are eligible for 10 individual sessions, and then the nurse or health practitioner services, which is either, like for the GP CCMP review, helping with that is 5 services a year. In terms of the referrals that you have to write, there's not a pro forma as such. It's the same as a referral that you might write to a medical colleague. The allied health practitioners are required to provide a written report back to the GP, and the difference between the referrals to a medical colleague and under the GP CCMP is that those referrals last 18 months instead of what is normally 12. So there's a list here which I won't go through about who are the eligible allied health practitioners that you can potentially refer to under the chronic condition management plan. But again, thinking about sort of different strategies in ADHD or thinking about comorbid conditions, possibly the common ones would be something like an OT for behavioural and emotional regulation, or for handwriting if there's specific learning difficulty in that area, and sometimes you can access psychology through that pathway as well for those kind of things, but noting that separate to a mental health care plan and kind of different from that point of view, and different rebates available, and some nuance about whether you can and cannot claim the same primary diagnosis for a mental health care plan as well as GP CCMP. So I would look into that yourself. So the mental health care plans, and I know we're all very familiar with this as well. Essentially, if you haven't done the additional mental health training, which is the online course generally, then I would recommend doing that. And these are generally the 2715, then if you have, or if it's longer, 2717 item numbers. So the things that are required on this is actually a diagnosed mental disorder under the WHO definition, and there's under the MBS a bit of and you can click out to what that actually looks like. So they're very much more the anxiety such that, is often accompanied with ADHD, or the low mood and depression kind of things. There does need to be an administration of an outcome tool like a K10 or a DAS as part of the mental health care plan, or a documentation of why it might be clinically appropriate if it's a very young child, for instance. There are some reasonably robust scales like the Spence anxiety scale to kind of delineate different types of anxiety, as kind of Rona had mentioned as a comorbid condition. But they are pretty time consuming. They're freely available on the web, and they self-scoring as well. So it might be something that you sent home with the patient and their family to fill in to bring back when you did need to see them again, so that we're talking about a long-term condition and lots of, therapy and coping strategies over a long period of time. That might be an option. Once you have completed the mental health care plan, then you can refer for these subsets, so different allied health, as in clinical psychologist or allied health focused psychology strategy services by registered psychologist, essentially mental health occupational therapists, and they are not all mental health occupational therapists, so it's important to know if they can claim under the mental health care plan for your patient, or social workers, or other focused psychological strategies services performed by, for example, GPs that have extra training in that. Again, this is limited. It's 10 individual sessions per year with an additional 10 group services per calendar year. And there are a few, not many, but a few private places around that do run sort of group sessions for children. The mental health care plan difference as well from the GP chronic condition management plan is that the mental health care plan can be done with a patient's usual GP, and it does not have to be done with a registered My Medicare practice, and that's recognition that patients may choose to go away from their registered My Medicare practice for the purposes of their mental health support. So it is a bit more flexible from that point of view. There are some changes from the 1st of November, which is very, very soon, which does actually remove the review and consultation item numbers. So that's why I haven't put them up today. And that's been changed then to essentially say that GPs can use time-based numbers instead, such as a 23 or a 36, depending on the time that's taken. One of the kind of murkier and more difficult areas of the MBS are not particularly well known is the complex neurodevelopmental disorders and eligible disabilities referral pathway through the MBS. And I am going to split them to discuss the main differences in a minute, but things that are common to both of these pathways is that the patient does have to be under 25 years of age. They have to have a suspected or diagnosed complex neurodevelopmental disorder such as autism, or one or more of the eligible disabilities. So if they do have this and you can refer for allied health assessment initially, and patient can access up to 8 services per lifetime, and individual course of services is up to 4. So you'd have to kind of review and accept that it was required for more assessment. The treatment course can a maximum of 10 in the lifetime of the child or patient as well. And again, a course in this instance of treatment is up to 10 services. And the list of allied health providers that are eligible under this plan is shorter, so more succinct than previous. Similarly, the referral must be in writing and the referral lasts 18 months, sorry. So I'm going to focus on the complex neurodevelopmental disorders pathway to start with. That covers patients who require support across multiple domains. So essentially there needs to be evidence that support is needed, which implies some functional impairment in the child, and that impairment is across 2 or more neurodevelopmental domains. So, for example, gross motor, speech and language, fine motor, etc., social and emotional. And it's not very prescriptive, and it's up to the practitioner's clinical judgment whether or not a patient meets a complex neurodevelopmental disorder. But the main thing to note for GPs is that GPs cannot access and refer for this pathway. The only consultant pediatricians and psychiatrists that can bill Medicare eligible items can refer for allied health under this suspected or diagnosed complex neurodevelopmental disorders. Okay, so there is a bit of confusion about that, but that is the Medico rules. It's important to note as well that in a public, so for example, the Child Development Service, they do not bill Medicare eligible items. And so they, in and of themselves, although they are, very specialized developmental pediatricians, cannot refer to access and unlock these particular allied health item numbers. So it's really more for patients that access private pediatricians. From a general practice point of view, what we can refer to is a relatively small number of mostly genetic conditions that inherently have complex neurodevelopmental disorders associated with them. So there are rules there. I'm not going to read them all out, but vision impairment, and they list the criteria for that. Particular criteria for hearing impairment, if there's deaf blindness, cerebral palsy is on that list, and then a number of genetic conditions there. Microcephaly, only if the child has a head circumference less than the 3rd centile and has an intellectual disability diagnosis, basically on a cognitive testing, then they would be eligible for the allied health assessment and treatment options from that point of view. Rett, fetal alcohol spectrum disorder, and a few others there. From the 1st of March 2026, the government has allowed to include stuttering, speech sound disorders, and cleft lip or palate. So they're expanding the eligible disabilities that GPs can refer for, again, the same, the assessment items and then the treatment items. Essentially, the item numbers that are needed to refer to allied health really are the time-based item numbers. So there's not a specific different amount that you get back for doing this, but you just need to write specifically that you're referring under the eligible disabilities and up to a course of either 4 for assessment or 10 in a course for treatment. Just to note on the complex neurodevelopmental and eligible disabilities, I've sent out some resources, the website that is the most, up to date on that from the government, which is quite clear about it. It's just a lot of pages of things. So before I jump into case conference numbers, there is in the suite of the GP chronic condition management plan, there is another item number 729, which is related to contributing or reviewing a multidisciplinary care plan that was prepared by another provider. Now, I'm not sure in practice how much this is actually used. You would have to have a provider, you'd have to have someone else, like an allied health provider, do the care plan and then as a GP contribute to it. But it is a non-attendance item that you can claim. There does have to be, in this instance, there has to be 3 practitioners involved. Only 2 of them can be medical practitioners. One has to be either allied health or like a paid carer can potentially be a provider, but not an unpaid carer. And then there are some rules and stipulations about that because it's part of the chronic condition management plan suite. You can't claim that item, non-attendance item number, if you've done a review, GP CCMP review in the last 3 months. So it has to be separate to having had a review or further away from that. Essentially, it's almost like what we used to call a chart review. And then the other part of that is that it cannot be claimed by a GP that if another GP has claimed a GP chronic condition management plan in the last 12 months. So essentially saying that it really has to be the usual GP that does that contribution to the multidisciplinary care plan. Finally, I wanted to just mention case conferencing with a note to sort of say that we are really hoping to move towards doing case conferencing in the child development service and PCH more as we do shared care with GPs, and accessing this item number hopefully will be part of that. So case conferencing is a non-attendance item number, as in the patient doesn't have to be in front of you or on the phone, but it does require 3 participants, again, similar to the contributing to a multidisciplinary care plan item number. This item number is time-based depending on how long the conference takes, and then the amount that is claimable depends on whether the GP arranges the case conference or whether they participate in the case conference. So at this stage, the Child Development Service doesn't really have the sort of infrastructure and capacity to kind of regularly do case conferencing, although it is something that they are certainly working towards in the future to improve patient care and GP involvement. I'm going to hand over to Jamie Lee.
Perfect. Thank you, Dr. Bowden. And thank you, Dr. Kelly, as well, for what you've been able to share with us tonight. We do have a couple of questions in the chat. So the first one is, do we know the current wait time for assessment at the Child Development Service and NDAS?
I'm always going to take a pause because it's such a complex question. I'm going to assume that this is probably for autism assessments if you've used the term NDAS. So put really carefully, there is constant thought and movement and funding changes in this area. And so this, the number will also change. And I think it's probably not in anybody's best interest if I throw a number out and then it doesn't turn out to be true, or it turns out to be worse or better than expected. But essentially, we are undertaking many more autism assessments every year. And NDAS are doing the same. They've also received lots of funding, and many more autism assessments are done each year as compared to the previous year. I think I would be safe to say that for most children referred to our service, again, depending on their age, the waiting time is usually between 1 and 2 years. But I cannot be more specific than that because, again, it's such a movable thing. And despite increase the amount of services that we do and the amount of assessments that we do, we have an equal and sometimes eclipsing number of new referrals being put in. So it's something that I can't answer most definitely.
Perfect, thank you. Another question is, we just moved. I'm not sure by what you mean with billing complex neurodevelopmental disorders. Should we claim item 139? I think, Dr. Bowden, this was when you were speaking on that.
Yeah, so the item number 139, I think, is a physician or pediatrician item number, and GPs are not able to claim or bill that. There is a very good flow chart about it. Essentially, for the complex neurodevelopmental disorders, the role of the GP is to refer to a pediatrician, and then we cannot access any further assessment or treatment from allied health as a part of that. We can access allied health and treatment if they have a prescribed eligible disability from a GP perspective. but not if they have a complex neurodevelopmental disorder. So no, GPs can't claim the item 139.
Perfect, thank you. Another question we have is, have we got more details on 2026 arrangements for anointed GPs who have completed ADHD training, diagnosis and treatment? Oh, sorry, I think you are mute. Yeah.
Sorry, it's in the Q&A.
Okay.
Thank you for the question. Personally, I do not, but from the knowledge that I do have, that the first cohort of GPs are undergoing current training, but I'm not certain the date at which that's finished and then what their post-training supervision is. But certainly colleagues within RSEGP might be better able to answer that question because they've been running the training alongside the AADPA.
Perfect, thank you. And the last question that we have is, does pharmacological treatment of ADHD improve a comorbid learning disorder?
Again, really good question. I think essentially it kind of depends whether the primary learning issue is to do with the executive function difficulties with ADHD, so things like working memory and processing speed, or whether the learning difficulty is due to a different kind of neurodevelopmental pathway around understanding and interpreting language or numbers. So with medication treatment, we know that there's good evidence that it helps to support those kind of phenotypic symptoms that we see on the outside. So things like attention difficulties, organization, hyperactivity, and impulse control. But in terms of acting on specific executive function pathways or learning pathways, I think that's a little bit harder to make a definitive comment on.
Yeah, perfect. Thank you. And thank you, Dr. Bowden, for also putting that resource in the chat. We don't have any other questions, which is great. So thank you all for those questions and for participating in the webinar thus far. I just also want to make mention to the clinician assist pathway that was mentioned earlier in the webinar. So we now have a pathway for ADHD in children and youth. So if you haven't already gained access to clinician assist, you can do so by registering on their website or by scanning that QR code. Because I will definitely recommend. Our team at WAFA has been working diligently to get that pathway up and running, and it's definitely full of useful information and resources as well. And on behalf of myself and our presenters this evening, we thank you for joining. Our next session will be on the 19th of November, and we'll be looking at commonly used medications for ADHD, common adverse effects and common issues that can be addressed in primary care, medication issues regarding compliance and diversion, as well as medication issues regarding or requiring, pediatric review. So I have put the link to the registration page for that webinar in the chat. Oh, sorry, Dr. Bowden,
I just wanted to reply to Sabrina, if that's okay.
Yeah, of course.
Before the next webinar. So that is for eligible disabilities. The 139 is for eligible disabilities, sorry, but not complex neurodevelopmental disorder. So GPs can't claim that for a complex neurodevelopmental disorder only. The child or person under 25 would still need to have a eligible disability.
Perfect. Thank you for clarifying that for us. And thank you everyone for joining us this evening. We really appreciate you taking the time to attend the webinar. I have got a QR code there on the screen, and that's just for our feedback survey. So if you did find this webinar really helpful for your practice, or you would like to give any feedback, any future topics as well that you might be interested in, then please go ahead and fill that out. I will leave that on the screen for you guys as well, so you can also access it once this webinar is finished. And we would like to wish you all a pleasant evening. So thank you for coming.
Thank you, everybody.